And it's now my pleasure to ask Remus Frei to summarize international data. Remus, the floor is yours.
Thank you very much, Michael, for your introduction. And Stefan, thank you very much for your very kind invitation. It's a pleasure and an honor to be here. So, my first slide, please. This is endoscopic treatment of net in the rectum. I will show you the data on the techniques that we saw right now. So, the incidence is low. We heard about the incidence rate is about 1.2 in 100,000, but it is rapidly growing since we're doing screening colonoscopies and since we are alert on these lesions that we find usually as submucosal lesions appearing as yellowish, small, roundish lesions which are located 5 to 10 centimeters from the anal verge. If you find a lesion like this, it's almost always a neuroendocrine tumor. We have to recognize that 50% can be symptomatic with bleeding, changes in bowel habits, weight loss, or pain. Most of the lesions that we found are small. 80 to 90% are below 1 centimeter, and the 5-year survival rate is excellent. The metastatic potential is low. If we have lesions below 10 millimeters, which are the very 90%, as I said before, so most of the lesions come in that size, it's like 2%. If the lesion gets bigger, the metastatic potential rises up to 10 to 15% for lesions up to 20 millimeters. And that was the discussion before. When should we stop with the endoscopic resection? It's more an oncological point of view than an endoscopic technical point of view, I would say. So what is risk factors for metastases? It's increasing tumor size, as I mentioned. It's increasing mitotic rate. I will come on that. It's lymphovascular invasion on histology and depression or ulceration on endoscopy. We saw beautiful pictures before of you, Michael, and you showed us very nicely pictures that have depression and ulceration, which are risk factors actually for metastatic disease. So, what should endoscopists know about staging and grading of neuroendocrine tumors? We have the T1 tumors that are divided in A and B. These lesions are always smaller than 2 centimeters. The T1A is below 1 centimeter. 90% of the lesions are T1As. The T1B is up to 2 centimeters. And then we have the T2 tumors. They can be either small but invading the proper muscle layer, or they are larger than 2 centimeters. This is the World Health Organization's grading of the neuroendocrine tumor. It's new since 2019. So we have the well-differentiated nets, G1 to G3, according to the mitotic rate. You see it on the right-hand side. Then we have the poorly differentiated lesions called neuroendocrine carcinomas when they have a high mitotic rate, which can either be small or large type. And then we have this MINEN entity, which is a lesion that has mixed neuroendocrine and non-urocrine aspects. So those lesions who are for endoscopic resection, they fall into the upper two, which are nets G1 and G2. I come on that. So we talked about EUS. Should we do EUS or not? The guideline is still the actual guideline of the European Society of Neuroendocrine Tumors. They say, yes, we should go for actually even in the small lesions, and I will show you why. This is a lesion on the left-hand side that you showed us before. It's a submucosal lesion. It's a yellowish lesion. It's small and is 5 centimeters from the anal verge. And you can nicely see on the right-hand side on the EUS that this lesion is really in the submucosa, so it doesn't reach the proper muscle layer that you see as hypoic layer. So the EUS is very important actually because 10%, even 10% of the small lesions, they are actually infiltrating the proper muscle layer. And if we have infiltration of the proper muscle layer, we need a more invasive resection technique. That's the rationale behind why we should do EUS. We can probably discuss that afterwards. So in EUS, we look for size, depth of infiltration, as I mentioned, and for lymph nodes to guide our therapeutic and resection strategy. EUS is very accurate. You see below, we are very accurate in confining the depth of infiltration and also the size. I will show you that. This is a little bit a busy slide, but I will guide you through. Also, the question comes, when shall I do staging? When do I do CT, MRI, or when do I do a special functional imaging like the gallium dotatate PET CT? When should I do that? So the guidelines say us very clear that after, when we find a lesion that looks like we've seen before, we should go for EUS. And then we find a lesion that is smaller than 1 centimeter, which is a T1, means no infiltration of the proper muscle layer. Then we can go for endoscopic resection. It's a T2. Then we have a T2, which means we have an infiltration of the proper muscle layer. We can go for a complete local resection, which can be endoscopically done by a full thickness resection. If we have larger lesions, a T2, we should go for MRI and ZT just to have further imaging because the risk of metastasis grows. And if we have a lesion larger than 2 or a G3, then we should go for the specific functional imaging as a dotatate PET ZT. So this is what the guideline still says from the European Society of Neuroendocrine Tumors. Now, what are these endoscopic resection techniques now that we have? We told about EMR, standard EMR, so submucosal injection and then simply snare resection. Then we have the modified EMR technique. We saw band ligation. There is also cap-assisted, and there is another method called EMR with precut. I will come on that. Then we have the proper ESD, and the most invasive, I would say, or the resection technique that goes deepest, the endoscopic full thickness resection. This is the spectrum of endoscopic resection techniques that we have, and I will give you now the data on these techniques. So EMR, we heard EMR is not enough, and EMR is really not enough for resecting these lesions. You see the classical standard EMR technique. So we found the lesion, injection submucosal is done, and then a snare is placed and the lesion is resected. And what do we see? That the conventional EMR technique resects R0 in only 74%, which is, of course, not acceptable for this lesion. So we come to this ligation-assisted method, or to this modified EMR technique as we saw before. This is 148. This is the largest study that I found on this ligation technique. 120 were ligation-assisted, 28 were standard EMR, and you can see nicely below that the ligation technique gets much higher R0 resections and curative resections than standard EMR does. So the thing at least that we have to do is a modified EMR technique, not to go for just a simple standard EMR, even though the lesions are small. So if we see the problem here, actually, is that normally we don't get deep enough with a standard EMR. That's the problem. So with a standard EMR, you see that we have, in a large percentage, we have the base margin that is not free. That's what you mentioned before, Michael. So you simply don't get too much submucosal tissue to resected R0. That's the problem. Then we have a second technique. We didn't see that, but I think a lot of us do it, resecting also other polyps, is this pre-cut technique. So in this technique is also we inject the submucosal tissue and then a circular incision is done. Usually we use the snare tip. We can use the same snare to incise and to resect the lesion actually, which is very cost effective. And what we see is here lesions below 10 millimeters, but even above 10 millimeters, 12%. What is the data on that? We had histologically complete resection in more than 90%, which is very close to the one with the band ligation device. The complication rate is very low, so it's also a very safe procedure. Then we have the question, should we go for ESD in these lesions? This is a large study with 430 patients almost, with 450 rectal nets, who are treated either with a modified EMR technique, cap or ligation, and 260 patients were treated with ESD. 19% of the lesions were more than 10 millimeters, and as we heard, the ligation therapy has the limit of more or less 1 centimeter because of the size of the cap. Very safe procedure as well. And what we see here is that the ESD and the modified EMR technique, they have comparable results, so they get in more than 90%, they get curative resections. The procedure time is shorter in the modified EMR technique than in the ESD technique, and the complication rate is the same. So, come to the most invasive lesion that we had a beautiful example from Patrick from Lucerne. So the endoscopic full thickness resection being done with this over the scope device. You see how the technique is done. Patrick already showed us very nicely. This technique gives full thickness resections in a high percentage of cases. We could show that like some years ago, and is a very safe and a very effective technique, removing submucosal lesions or recurrent adenomas, and indications that you see on the right-hand side. But submucosal lesions are, of course, a very good indication to resect with this device. So, what is the data that I found? This is from the German Register of Full Thickness Resections. In their database, they found 40 rectal nets up to 25 millimeters, most of them below 10, as we know. R0 resection rate 100%. Full thickness resection very high for rectal lesions. Usually we have in the rectum not that a high percentage of full thickness resection, but still we get the proper muscle layer in almost all cases. So the important layer to decide what it definitely is, histologically, is in the resection specimen usually. They find no major adverse events, and the procedure time is 18 minutes, which is longer than for the other therapeutic options. So, I'm already at the end, and I conclude for rectal nets. We should do EUS actually in all rectal nets. This is because of these 10% of even the small lesions that infiltrate the proper muscle layer. And in these lesions, and I think this would be really a perfect indication for an endoscopic full thickness resection, because we resect the proper muscle layer with it. Small rectal nets below 10 millimeters that are just in the submucosa, they should go for a modified EMR technique. Standard EMR is not enough. Lesions from 10 to 20, which are a T1, which means they are only in the submucosa, they should go for even a modified EMR or an ESD, the larger they get. And if lesions invading the proper muscle layer, they are small, I already told you, endoscopic full thickness resection, if you can do it. Otherwise, it's a transanal surgical approach. And if the lesion is more than 20 millimeters, you should go for functional imaging and anterior resection and the systemic therapy following the histology. So I thank you very much for your kind attention, and I hope I gave you an overview about these techniques and about the data they give. Thank you very much.
Thank you so much for a really brilliant overview. We are coming to the end of this session, but I think that before we conclude, there is one thing that we should ask ourselves, and I think that all of our participants are asking as well. So should we offer these patients after endoscopy treatment surveillance, and what kind of surveillance should we offer to these patients? So this is very last question before we conclude and move to the break.
So with a small T1 that is resected completely, you don't actually need surveillance for these lesions. The guidelines of the European Society of Neuroendocrine Tumors gives us straight information about that. If we have an incomplete resection, it gets complicated, so you need a more advanced endoscopic resection technique. And these patients, it's a T1, they need endoscopic follow-up.
Thank you so much. It was a pleasure. I think that we learned a lot about this rare disease but relevant disease. Thank you so much.